Hi, everyone. Welcome to the Complex PCI Virtual 2020. And we are in the taped live cases for left main and bifurcation PCI session. I'm Dr. Gu from Seoul National University Hospital, and I'm co-moderating this session with Dr. Antonio Colombo, who doesn't need any introduction. So having said that, without further ado, I'd like to introduce the first speaker who's going to share the case, left main bifurcation PCI, Dr. Sunao Nakamura from Japan. Dr. Nakamura, please.
Good afternoon, ladies and gentlemen, Professor Ku and Antonio. I miss you. Thank you very much for including me in this nice session. This is from Japan, Sunao Nakamura speaking. Anyway, let's start my case. This is a case of 83-year-old gentleman who had a stable angina and also having a history of PCI in the LED 2 years ago. Because of the progression of the angina, he was back to the hospital. Actually, he was 52% ejection fraction, big ischemia was shown in scintigraphy, and several coronary risk factors with slightly decreased renal function. And this is actually just to explain the ECG, quite normal pictures. This is angiogram, RCA, no significant stenosis. This is left system, as you can see, beautiful true bifurcation region in the left main, and also another true bifurcation region in the mid circumflex. This is another view, left main true bifurcation region. So the case was a double true bifurcation region in the left main the circumflex. So first discussion is that this is ATC, a gentleman who had left main bifurcation, the severe stenosis, of course. Actually, need discussion with the surgeon, but actually, okay, this will go to PCI. And if you want to do PCI, what type of complex stenting we need to do, or another option? This is first discussion.
Okay, so that I think the questions are quite heavy and quite wide. So that the Thierry, do you have any thoughts on these questions?
It's a complex case, so I think we should discuss about surgery in this case. But PCI is also a good option in experienced hands like Sunao Nakamura. I think if we do go to PCI, I think I will treat first toward the circ. Because the lesion of the proximal LED is not very severe and the access is relatively simple. So I will wire the 3 branches, LED, circ, and marginal, then stent toward the circ, then do a proximal optimization technique at the level of the proximal circ, just proximal to the marginal, then do a pot at the level of the left main, then do a kiss between LED, between circ and marginal, and open the strut toward the LED and put a stent in the LED as a T-shape or tap configuration. Of course, there is other options like decay crush. I think Sunao like decay crush in complex lesion.
Actually, I don't like.
Okay. Good. Okay, and of course, a culotte technique can be also a good option. So, yeah, so I think it's feasible, but needs good operators to do it.
So, Dr. Tan, any thoughts from Asia? Different thoughts from Asia?
I think a two-stent approach is reasonable, although if you go by the definition criteria, it's not exactly a complex PCI because these complex lesions may be short, so a little bit short. So I like to consider the LED as the main vessel here. So you could go for a provisional first, and then do a ballooning of the circuit, and then decide what you want to do after that, or you could do a two-stent. So I think both ways are feasible.
Maybe all of you want to see IVAS.
Right, you were right.
So maybe I think present for you IVAS pictures from ready to left main and circumflex to left main. So actually, we had a coronary CT beforehand. Upper panel showed the IVUS picture corresponding to lower panel of coronary CT. The point is we had a calcium deposit left main to the LED and OM, but no calcium deposit in the circumflex. Again, no calcium deposit in the circumflex. Much amount of the plaque in the circumflex. This findings contribute to make a decision of the strategy. Look at the circumflex. I was finding the circumflex. There's a big burden, more than 80% plaque burden, as you can see. So, like you said, evident belief. If we can finish one stent in a left and bifurcation area, long-term result will be very nicer. But in this session, looks a little bit difficult to avoid the two stent. What kind of stent technique? What would be the prefer? Actually, we have a two big dogma in this area. Can you continue? Provisional stenting in a European group. DK crush with DK crushers. And of course, sometimes another stenting technique and the others.
Don't be trapped by dogma, which is living with the results of other people's thinking. Don't let the noise of others' opinions drown out your own inner voice. And most important, have the courage to follow your heart and intuition. They somehow already know what you truly want to be.
I wanna divide the three parts. Left main to the LED. Okay, diffuse region, left main to LED, with some superficial clarification, which is not good for the special device for we consider. But easy to implant a stent. Circumflex, short region, big plaque burden, few clarification. This is actually quite good for the DCA. And circumflex OM, diffuse region with some superficial clarification. Looks easy to deliver the stent. So a point is using DCA and DCB. If we do DCA in this area, maybe we can avoid a complex overlapping stent in the left embarkation region. This is our idea. Can you continue? Can I continue?
Yes, please.
So let's explain the procedure of DCA. At first, we need a test cut like this. Of course, we can recognize with a window DCA cast. So we can estimate the region of the cut point. However, we need to confirm by the IVUS what you did right thing. After we confirm, we need to proceed next step. Again, after confirming what we did the right thing, and then if we confirm the IVUS, need to proceed next step. And anyway, by the IVUS finding, we always get the orientation and need a cut of the number of the cutting. We start in a low pressure, 1, 2, 3, 4, and then totally like around the 30 cut. After totally around the 30 cut, we need to recognize how much plaque burden we already removed. Totally, before procedure, big plaque burden, 89%, and after process this year, less than 40%. This is a serial IVUS measure after the DCA with 1, 2, 3, 4 ATM, totally 29 cut like this. In this each procedure, we was checking with IVUS to make sure. Then just DCB in all circumflex, understand in OM, understand in left main, and then do the cavity and then final pot. And this is the final angiogram. So-called this is a hybrid strategy, but this is a final IVUS. So how do you think? Pre, post, avoid two overlapping complex stenting. This is actually final angiogram. Of course, we did follow-up 4 months, 10 months, or 16 months, of course, checking physiology. So far, it's okay. So next discussion point, this is one of the best useful device for the best preparation. But if you want to do DCA, we need several conditions. Of course, indispensable to use IBUS and should be very familiar with. And if you have a superficial qualification, a little bit difficult. And of course, we have a learning curve, need technique. Of course, if we can not do DCA, we should be very sure of the complex stenting, even in a complex situation. So how do you think that?
Okay, so that any thoughts and comments from the panel?
May I ask a question? I have to congratulate my good friend, Dr. Sunao Nakamura, for his very skillful technique. I have two questions. And first one is, what degree of arteroablation is considered as appropriate ablation, appropriate lesion preparations before you embark on doing applying drug-eluting balloon dilatations? And secondly is, what degree of calcification is considered as contraindications? So in terms of length of the calcium and depth, and also the calcium arc, or any calcium is considered a contraindication.
Maybe I think I need 1 hour to explain all. So first of all, I think around the 30, at least 30% case, maybe we can do something in the left main bifurcation area. Around 30, because of course we have a superficial clarification. It's really difficult to cut, of course, but not so big superficial clarification, maybe we can cut. So it is depend on the doctor's, operator's skill. The first of all, this is very, we have a learning curve. It's very depend on the operator skill. This is very true, first of all. But if you are good enough, around the 30% case, we can modify the region. And the point of this, my presentation is, if we can avoid overlapping two stem, maybe this is quite nicer. This is my point. And like Santoso, my good friend, ask me how much clarification. It's depend on the maybe operator, and also the angle. It's maybe I think a sharp angle, very difficult to deliver the DCA cast. Maybe a little bit shallow angle, it's much easier. And the location of the plaque, also maybe we need to consider. But also, we should have all knowledge about the DCA.
So I think it was asked by the Teguh that so that you've done 29 cuts for several times, doing several IVUSs, so that what is your criteria for success of DCA? So that residual 30%, 40%, 50%, or lumen area criteria exists?
Very great question. Actually, currently, of course, maybe since Santoso and Thierry maybe already know, we have maybe 20 years ago, we have a DCA. At that time, actually no DCB and no good stent. So maybe I think at that time, maybe our goal is less than 40% residual plaque. But maybe I think in the era of the DES and also DCB, we should have a goal of the less than 40%. Now I think. But currently, some Japanese say around 50% okay. But I mean, I think anyway, we need the data of the after DCA and plus DCB, we need a follow-up data. But so far, if you look at our data, maybe I think less than 40% residual plaque and the DCB is going to be a maybe better clinical result. Just I think.
I think Sunao is really a great case, and we are learning because I have done few DCB cases in the 80s, but not now. It's not available in Europe, or maybe
Yeah.
in Korea it's not available. So we need your data. It's very important if we want to resuscitate in Europe DCB. I think we need very strong data showing that the safety is okay, and follow-up at least 1 year is good in terms of restenosis.
Give me,
So,
okay,
yeah.
give me 1 minute. Actually, not only the reducing the number of the 2 to 1, sometimes 1 to 0, stentless, like this.
Yeah.
And so far we have 31 cases in the left main bifurcation area, and so far it's okay. And so finally, I want to say, DCA is very useful. But if you want to do DCA, need a very patience. Cut IVAS and cut IVAS and another cut IVAS. Sometimes additional cut, even a flap. So one German philosopher, Jonathan Siller, said, only those who have a patience to simple thing perfectly will acquire the skill to do difficult thing easily, like this. This is my final slide.
Great.
Thank you very much. So now I hope that next year at the EBC you will be able to come with more data, more follow-up with DCB. I think it's very promising. But in order to convince people in Europe, it will be very difficult without strong data.
Actually,
Can I ask one more question?
Yes, please.
So now, what is the maximum pressure that you are allowed to apply in the DCA balloon? Because otherwise we may also get dottering effect of the lesions and get the enlargement of the vessel of the lesion.
Anyway, actually, honestly saying, this is a case of my friend, my junior, Okutsu. He's one of the panelists here. And he is very, very patient, more than 100 times patient by lecture, compared to me. And he used 1 ATM and 2 ATM and 3 ATM and 4 ATM. Actually, maybe I think Thierry and me, maybe I think not so patient, I think. So easily, up to the 6 ATM, 8 ATM. But anyway, this procedure should be very patient and then slowly increasing the pressure 1, 2, 3, 4, and they cut many times. Maybe I think this is a very important point of the DCA.
So now you're warning us that we should be very, very patient. So that what was your procedure time for that left main case?
Yeah. Improving the humanity, I think.
So I have a short comment. I think Sunao this is a very wonderful case, very representative case how work the DCA as well as DCB work for this left main disease. But I think, however, left main artery has a very strong recoil, elastic recoil.
Yes,
If clinical event happen, patient might experience very severe catastrophic clinical event, and so
Yeah.
I think more big data and the more comparison data require to confirm how work the DCA for left main disease.
Okay, thank you. Anyway, very technical demanding device.
Right.
Anyway,
So that but so now you and your team are doing resuscitation or CPR for the DCA. So I hope that you survive the DCA and make a bright light to DCA in near future.
Okay. But actually, not so risky, but that's a little bit taking time and need a technique. This is DCA. Anyway, thank you very much.
Okay, thanks now for sharing the great case and the opening of the reviving the DCA. So that for the sake of time, I'd like to move on to the next presenter, Dr. Jung-Min Ahn. He's from Asan Medical Center, but now in the United States, and he's going to share another very interesting educational left main bifurcation case. Dr. Ahn, please.
So my topic is left main bifurcation PCI. The compared with the Sunao's case, my case is a very stent-oriented treatment case. So the bifurcation stenting, yes, nowadays this left main disease, one stent technique would be the standard if indicated. So the extreme one stent cases was shown by the Dr. Sunao in previous case. However, two stent technique is inevitable in some situation. Based on the contemporary randomized trial, pre-combat Excel trial, novel trial, the 50%, 35%, 40% patient receive the two stent technique. In addition, the simple crossover stenting is not always simple. Look at after the ballooning, unexpectedly, the big side branch jailed. In this case, inevitably, we have to do the two stent technique. So I think sometimes the simple crossover is not that simple. The Sunao is very expert in the simple crossover stenting, but sometimes the two stent technique is more simple than simple crossover stenting. So I like to start with the case. 82-year-old male was admitted for the evaluation of aggravating effort chest pain 1 month ago. So unstable angina and echo showed the severe aortic stenosis. Previous history showed the cerebral aneurysm and lung disease. 82 years old male, severe AS and lung disease patient. This is a coronary angiogram, RCA, fine, but the left main trifurcation case, high diagonal branch, circumflex, and proximal AD. So how to treat this patient? Well, can you give me some advice for this patient stent strategy, treatment strategy?
So this is a old gentleman with the severe AS. So that just for introduction, for the information, did you have a pre-designated plan for severe AS for this patient?
Yes, severe AS patient.
So TAVR is planned, or they just medical treatment, or the
SAVR or TAVR. Anyway, we have to treat the severe AS. So we plan to the TAVR.
Okay. So any thoughts and comments for this complex lesion, severe AS patients? Any comments?
Jung-Min, nice to meet you here, and I have some idea about this patient. I think first you should wire LAD, circumflex, and diagonal, and dilate slightly iris first, and then make you decide what strategy you will choose. Hopefully, to treat this patient, use single stent crossover.
So I like to go forward my case. So thank you, Dr. Do. So yes, I did the IVUS first because IVUS is very important. Based on the IVUS finding, proximal LAD is a huge plaque and very tight. High diagonal is not that small and some plaques, but angiography is very tight. Circumflex is also very severe plaque, and vessel size is more than 3.5. So the left main bifurcation with very tight high diagonal lesions. I think the simple crossover stenting is the standard, and if I succeed the simple crossover stenting, it is the perfect scenario. But considering very old age and severe AS, if I lose any one big side branch, I think there is a risk of a sudden collapse of a patient, considering the very tight stenosis. So initially, I planned the complex bifurcation stenting to save the bifurcation side branch flow. So I selected the cross technique at the high diagonal branch and circumflex branch. So I think IVUS is a key. So because when we use IVUS, we can put the larger stent and IVUS guidance can save the lives in the left main disease. So I performed the pre-ballooning and zip high pressure balloon 275 after the wiring in the LAD, circumflex and high diagonal branch. And then side branch stenting first, high diagonal branch based on the IVUS sizing 275 18 millimeters and Giants 3.5 15 millimeters for circumflex, and side branch stenting done first. So I think for the side branch stenting for crush technique, open side branch ostium as wide as you can when you implant side branch stent is, I think, very important. It's because the side branch ostium is the most common place of restenosis. We know, everybody we know it. So this is my live case. So after the side branch stent implantation, this is a balloon. After side branch implantation, I pulled back a little bit and then expansion stent balloon one more to open side branch ostium as big as we can. Sometimes this is another case. This is side branch before balloon crushing. Even after the side branch ballooning, side branch stenting, side branch ostium stent is not well expanded. Look at some indentation. In this case, sometimes I remove the stent balloon and insert another high pressure balloon, and then I inflation balloon one more using high pressure balloon to make sure the side branch stent expansion. Like this. So before side branch stent crushing, so we have to open side branch stent ostium as big as we can. I think this is very important for crush technique. So for the side branch stent implantation, I perform the balloon crushing, and then this is after the balloon crushing. Angiography show that every side branch survived and anterior flow is very nice. Patient vital sign is very stable. And then thereafter, side branch stenting and balloon crushing to the circumflex stent and diagonal branch stent, I implanted the LAD stent based on the IVUS sizing. This is after LAD stenting. After LAD stenting, what is the next step? Side branch rewiring? I don't think so. Before side branch rewiring, I did the LAD stent optimization using very high pressure. The NC balloon 3.75 up to 3.89, left main area 4.0 up to 4.15 up to 20 atmosphere. Because the main branch is more important than side branch, main branch stent optimization after IVUS evaluation before rewiring makes the side branch rewiring easier. And before side branch procedure, main branch stent, particularly in left main and POC area, should be well opposed and fully expanded. So this is the concept of part technique. This is before part, this is after part. After part, after main branch, main stent optimization, main stent well expansion and well opposed vessel wall, then it facilitated the side branch wiring and balloon delivery. So which wire do you use? Many times the audience asked me while we did the live demonstration, but I think if you do open side branch ostium stent widely and main branch stent optimization, I like to call it the preconditioning for easy rewiring. Rewiring recrossing balloon would not be difficult, and special wire or technique would be unnecessary. So this is the side branch rewiring. After side branch stent opening, and then the main branch optimization, side branch rewiring is not that difficult. Very smoothly, we can do the side branch rewiring. So special wire is not necessary. And next, I did the sequential high pressure balloon, the LAD, diagonal, and circumflex. And the final kissing balloon, triple kissing balloon was done using very low pressure. So I like to say another idea, sufficient stent cross-sectional area is obtained by sequential high pressure ballooning, not by final kissing balloon. And goal of final kissing balloon is to place the carina in the right place, so high pressure is not necessary during the final kissing balloon. So sometimes anchor balloon technique is very useful to deliver the balloon to the side branch. Anchor balloon LAD and the balloon side branch ballooning, we can deliver the side branch balloon like this. So after final kissing dilatation, so I apply the high pressure to the left main up to 28 atmosphere. Finally, we perform the IVUS evaluation, and this is a final angiogram. So LAD stent, circumflex stent, and diagonal stent expansion looks fine based on the IVUS finding, and patient was stable during the procedure. This is epicaudal view and epicranial view. And then 2 months later, patient received the TAVR procedure successfully. So far, patient survived without any symptoms. So this is my final slide, step-by-step crush technique. IVUS is a key for the bifurcation stenting. Large opening of side branches stent of ostium and the main branch optimization, particularly POC area. My main branch optimization means stent expansion and stent opposition to the vessel wall is important for each side branch rewiring. Balloon anchoring is sometimes helpful. Stent area is obtained by sequential high pressure ballooning. The final kissing balloon is to place the carina in the right place. And final IVUS surveillance and correcting suboptimal result guarantees favorable long-term outcomes. Thank you for your attention.
Okay, so thanks for sharing the very interesting case and with the great techniques with the very complicated lesions. So any thoughts and comments? Antonio, so do you have any comments on this procedure as a father of crush technique?
I really like this refinement. I believe the refinements are very important. The pot is very important. We used to miss the pot at the very beginning of the crush technique and makes the crossing more difficult. I totally agree that opening the struts of the main branch stent is essential. And the other essential point is the sequential high pressure inflation. Kissing is okay, but is a little bit cosmetic. But the key is high pressure sequential inflation. So I think, and of course, it's important to do good lesion preparation, because if you have residual calcium undilated, that's whatever refinement you make is not effective. So good lesion preparation and the technique how described is perfect. Congratulations.
Thank you, Antonio.
Dr. Ahn, can I just ask you a question again? I just want to clarify the sequence of a stent placement. So you put a stent first in the circumflex, followed by the diagonal, followed by LAD, or is it diagonal first and then circumflex or LAD? What was the sequence of the crush again?
Yeah, thank you for your questions. So after ballooning, side branch is stenting first at the diagonal branch and the next the circumflex branch, and then using the LAD balloon, crush the diagonal and circumflex, both stent crushed by the LAD balloon.
You crushed two stents with one balloon.
Yeah, right.
Okay.
Fortunately, there is some. So if the diagonal branch and the circumflex ostium, two ostium close, located very close, then this technique may not be applied. But fortunately, there is some room space between the diagonal ostium and circumflex ostium, so I can implant the two stent to the two side branch and crushed by the one balloon.
So does that mean that there are 5 layers of stent on one side of the left main at the end of the procedure?
Yes. So I minimally protruded to the main branch. So the overlap is very minimal. So the only one layer each side, not the 4 layers.
And Jung-Min, let me ask you a question. I noticed that you do the final kissing, use 3 balloons simultaneously. And is there any concern to the 3 balloon open up will do some injury to the elastic membrane or something like that before? Because years ago I found a patient after underwent a case like you did, and finally there is a huge the vessel dilatation at the left main path.
So yes, thank you your question, Dr. Do. So the goal is I like to say that the final goal of final kissing balloon is not to dilate the stent more. So final stent area can be obtained by sequential high pressure balloon. So the goal of a final balloon is just the carina put in the right location. So I applied a very low pressure when I did the final kissing balloon, so the risk of complication is very low.
Yes.
So we don't need to apply the very high pressure.
Yeah.
I just want to underline the importance of the side branch optimization ballooning, as mentioned by Dr. Ahn. It's very important. And we also apply this routinely. I'm a great fan of DK crush technique. So if I do a DK crush technique, and I think with this side branch optimizations, wire access to the side branch would be much easier, and theoretically we will expect that the TLR will be much lower. And this technique, this important step, it has already been endorsed by the latest European Bifurcation Club consensus.
Thank you.
The technique is called PSO, proximal side optimization, in the EBC consensus.
Any comments from Thierry?
I think I would like to insist on what Dr. Ahn said about repositioning the carina in the middle. It's very important, especially when you do trifurcation lesions like this. So tracing balloon inflation is a very good option, and we always do that. And we have not seen any complication related to this triple kissing balloon inflation. The other point is the proximal optimization technique, like it was said by Dr. Ahn, also by Dr. Colombo. What is very important is to do it at the right place, because if you use the pot too much distal, then you push the carina and you may close the vessel, or you have a lot of deformation of the stent in the other branch. So very important to put the balloon just close to the carina, but not distal to the carina. And of course, select the balloon according to the size of the vessel proximal to the bifurcation.
Okay, so thank you. And for the sake of time, so we are going to move to the next non-left main bifurcation PCI case from Dr. Teguh Bak from Asan Medical Center. Dr. Bak, please.
Okay, I'm going to start my case presentation, and this case is a non-left main bifurcation region, and I recently experienced this case. I think this case is one of the most challenging case in my PCI life. So, and This patient is a relatively young, 51-year-old male with stable angina and a heavy smoker history. There is no diabetic, no hypertension, no hyperlipidemia, just only smoking. The ECG was absolutely normal and X-ray was okay. And ejection fraction 64. There is no regional wall motion abnormality, and every function is good. So right coronary is just a mild disease about prox RCA, and suck region just intermediate, and 40% is suck region. It's okay. We decide the medical treatment. You know, the target region is about the mid prox LAD bifurcation region. There is some looks like total diagonal obstruction, and the size is not so small. We should treat such a diagonal branch, and there is some LAD region. So initially, I think diagonal branch wiring is very difficult, but wiring is very easy. Just we use the cyan blue wire, and just one time try the past the diagonal branch region. So at this time, I think this procedure anatomically initially looks complex, but procedure goes well. And we put the LED BMW wire, diagonal branch cyan blue wire. We check the IVUS, diagonal ostium. There's some calcified region. LED also calcified region. I decide at this time the crush technique would be good to treat the big diagonal branch and LED. So I performed the diagonal branch NC balloon and using Emerge 2.0 NC balloon. After the NC balloon dilation, the diagonal branch is expanded well, and as shown here, diagonal branch size is not small. Definitely, we treat the diagonal branch as well as main branch. So I put the design on the basis of the IVUS evaluation size. Distal part is 2.6. I decide 2.75. Also decide the stent length 32 on the basis of the IVUS evaluation. So LAD is 3.5 NC balloon, and initially I put the design drug loading stent, Novorimos loading stent 2.75 32. After stenting, diagonal branch there is some distal part, some region, but the austere proximal part diagonal branch looks okay. So, and then I put the LED long stand over here, and after the 3.5, 2 and 3 time high pressure balloon dilation in diagonal ostium, after making crush, I put the LED long stand, the design 3.5, 38, and then I aggressively high pressure balloon using the first NC balloon 3.5, 15 from the mid LAD and the proximal part. This is the stent zooming, how much crush the stent. This using the 3.5, 15, the crush part zooming is morphology is okay. But the problem after crush and the acute chest pain, LAD stenting, high pressure, and as shown the spiral view, you can see complete obliteration of diagonal flow is definitely timid 0. So, and I'll have the interim discussion time over here. 51-year male, stable angina, LAD bifurcation is 011 or 111. And so different stent or different outcome for bifurcation lesion, we select the design, the open cell design, and if you're gonna select different drug loading stent, less diagonal gelling. Also, if you select a different technique, DK crush or balloon crush or good load, and the less diagonal complete gel, there is first my interim discussion. This is the design, the stent platform looks like coiled hybrid type, and the 81 micro ultra thin strut, and this is the platform of DS10.
Okay, so but I couldn't see the whole LAD IVUS, but the angiographically it's not that significant. So that from my eye, it's like a total diagonal branch occlusion lesion. So was there any findings in LAD IVUS that suggest that LAD lesion was also significant in this case?
Yes, we also evaluated LAD plaque burden 75, and the most narrowest part is the lumen area is 3.2, 3.3. So on the basis of the IVUS, we decided to stent. Also, we cannot treat well just the diagonal branch without any touch of the LAD at this region.
Dr. Park, I have a comment. First, for the LAD, maybe if we check FFR or something else, maybe it's not hemodynamic significant. The second thing is if you use a cross technique, use a synergy stent, right? I think synergy stent, there are more connectors in the several proximal struts. So when you crush it, maybe the more mental across the struts are occluded the side branch. I think that's the reason.
This is I used design stent. Yeah. So
Synergy,
and not synergy. Synergy is
Okay,
Boston.
okay.
Yeah. Design is Alexa
Okay.
stent. Yeah.
I would like to ask what is the reason for the side branch occlusion? The plaque shift or current shift or thrombus attachment on the gel strut or crush strut?
Yeah, so I think I don't know exact region is a total obliteration of the diagonal branch, and so after the hyper crushing, and there is some total obstruction. Is we don't have enough time at this time to evaluate the exact mechanism of something like that. The patient complains severe chest pain. There is some EKG change, and we gave morphine 2 grams and 4 and 5 times. Already catastrophic situation over here.
Can we see the last picture right before the occlusion?
Okay, got it. Okay.
The very last with contrast.
Yeah, this is a crush part, and then proximal over here. This is the people stenting LAD just after stenting diagonal branch. So 2 years ago, I experienced a similar situation for distal leg main. It's at the time I used the Ultimaster stent. It's after the stent crush, total obstruction of a sucker ostium like this. So at the time, I'm wondering is also the different stent. If I select and different result, and this I don't know is stent platform and the stent type can much predispose such like a total obstruction.
Can I show us that the baseline angio?
Okay, baseline angio over here. Okay.
One of the potential problem of using the current generation stent, which I usually have thin struts, is a concertina effect. So if we push our devices like balloon or other stents across the already implanted thin stent, we may push the proximal part of the proximal end of the stent, and then get the concertina effect. And this is one of the potential problem, and this has one that problem that we have to think in this particular case.
Okay,
I think IFUS or OCT would clarify the situation.
So, Dr. Bak,
okay, comment. Go ahead.
Dr. Bak, is it easy to insert a side branch wire?
Yes, it's initially after checking the coronary angio, I some expect the wiring is very difficult, but just a one-time pass, Xion blue wire, very softly past that lesion.
Okay, now please show me the initial IBUS.
Initial IBUS?
Yes, diagonal branch.
Yes,
yes.
This is just shows the ostium.
Yes,
and the mid part, there is some calcium, but there is no severe circular calcium, just plaque. This is shows the ostium of the diagonal, the ostium. There is some eccentric calcium.
Yes. Opposite side of the carina, the diagonal branch have a heavy calcification. This plaque are sometimes very difficult to dilate. And after the kissing burn inflation or the pot, and then finally the diagonal branch lumen, also lumen is frequently small. So my opinion is operation of the by the rotablator or the orbitalaterectomy or something. This is one option. How do you think?
Yes, I think that is one of a good option, but we don't have much experience in rotablation for side branch ostium.
I think the closure of the side branch is probably a combination of the angle of the diagonal takeoff from the LED plus the crush stent layers across the ostium of the diagonal. And actually, the proponent of DK crush will tell you that this will be avoided when you have done the first kissing balloon inflation after crushing that side branch stent. But anyhow, now it's a rescue operation.
So, and I move to the next step, and due to the limited time. So, and the patient complained the severe chest pain. We gave 4 and 5 times morphine, 2 grams is viral. Blood pressure is okay, but the one of a very catastrophic case, and so I tried to almost 1 hour to pass that lesion. The total obstruction of diagonal. Initially, I used Xion blue, failed. Choice PT, failed, and the field XT, failed. Crusade, failed. Gaia second, failed. It's almost I spent 1 hour. The patient continuously complained the chest pain, everything failed. So almost at the time of I gave up, and I tried to last one, desperate wiring a diagonal branch. This is a Conquest Pro 12, one of the most strong wire, and the diagonal os very luckily, but this at this moment I don't know this is true lumen and false lumen, but the diagonal wire finally successfully passed that region. This is one of the most strong wire, Conquest for the 12. Okay, that was a movement of the diagonal branch. And then the LAD anchoring 3.5, 15, and the Lacrosse 1.0, the smallest balloon is spent a lot of time over here, and more than 10 times it does not pass the well, that cell strut. And then the 1.0 compliant balloon is a 5 and 6 time inflation. I change it to Caravelle microcaster, and then put the soft wire Conquest Pro 12 to exchange it to BMW wire. And then this is some distal part testing that shows the true lumen. So LED anchoring, and then this is a Lacrosse a new NC balloon 2.75. And then after anchoring, the successfully passed, and the high pressure balloon dilation, diagonal ostium, and the diagonal, the proximal part. And over here, and we check the diagonal ostium. There is some calcium also, almost after up to successful wiring, the take 1 hour. There is looks like some mid part thrombus, and proximal part there is some layered thrombus, proximal part of the diagonal branch. So, and we decide the final kissing balloon aggressively, LAD, NC balloon 3.5, and the diagonal ostium used NC balloon 2.75, diagonal ostium, LAD sequential balloon, we did the kissing NC balloon is the 2 and 3 times. And then the distal diagonal part, there is some very tight stenosis. We decided additional stent 2.7523. And the final angiography, it looks okay. But the proximal part, there is still some hedginess. So, and the diagonal, proximal diagonal branches, there is some irregular and irregular lumen narrowing over here. A flow is okay. We checked the IVUS over here, diagonal ostium. Stent ostium is expanded well. There is some, you know, layered thrombus. So even though we 4 and 5 times kissing balloon dilation, this you know, image thrombus did not appear. So we finished at this moment and over here. So my final discussion and the side brain total gelling, different stand or different story, and the different technique or different story. The side branch wiring chaos during the crush technique. I think most of the panel and the, you know, moderator have experienced a similar situation. Even after repeat NC balloon and final kissing, interrupt procedural, the looks like stent thrombosis, plaque protrusion is remained. How to do? That is my final discussion point.
Okay, so Dr. Bach, now you are happy and successful. So that the what do you think, you know, after finishing procedure, what do you think? Because that there's a possibility, because after, it may be due to the long time occlusion, but there can be a thrombus and the distal edge dissection and no flow, because you need one more stent after the opening of the proximal stent. So what do you now think was most probable cause of this abrupt closing of this side branch or catastrophe?
Yeah, so I don't know. Frankly speaking, I don't know exact mechanism of you know, that story. Is a stent problem or a technique problem? So in my thinking, is that, you know, protruded the proximal part diagonal branch is not so wrong. So we try to minimal crush, so that is not problem. So now if I think if I'm gonna do DK crush before main branch stenting, I'm gonna do, you know, one step the kissing, that would be not happen. Yeah, that is some my thought. If I regret the overall procedure, if I'm gonna do DK crush, is some different story.
So for this patient, maybe a DK crush is good option. But there is some problem with DK crush. If you do the first time kissing, and then maybe some dissection occurred in the proximal part of the side branch. The second thing is after kissing balloon, some mental struct protruding into the true lumen actually will make it difficult sometimes to deliver the main vessel stent. So in Huay hospital, I usually call it DR crush. And first we implant side branch, then crush, wire it, and open the side branch cell, and then use a balloon crush again. We don't use the first time kissing, and then we deliver main vessel stent, then kissing. That will avoid what happened today for a case.
I was clearly showed the under expansion of the side branch stent. The reason why the side branch occlusion is the under expansion, because of the calcification located in the counterpart of the carina. So Dr. Okutsu say the root ablation for the side branch is the one option, and kissing balloon, recurrent kissing balloon inflation also allow to expand more in the polygon area, even the calcification located at the side branch ostium. So DK crash or more recurrent kissing balloon inflation at the side before member stenting, that is another option, I think.
Okay.
Yes?
First of all, I'd like to say congratulations, Dr. Park. As a doctor, I want to say respect your effort to rescue the patient. Maybe I think this is very important point. Like us, very old doctor have that kind of experience many times. and use a lot of the CTO guide wire like this.
Thank you.
Okay, so thanks for your kind efforts in showing the very complicated case. And now let's move on to the last speaker of this session, Dr. Thierry Lefevre, and he's going to teach us left main PCI expert tips and tricks 2020. Thierry, please.
Thank you very much, Dr. Koo. It's really an honor and pleasure to to give some tips and tricks when treating left main lesions on behalf of you, Antonio Colombo, and a very distinguished panel. This is my disclosure. So I think when thinking about left main, we should think what is the difference according to other bifurcation lesions. I think, of course, we are treating a large territory, and both branches are usually very important. We are dealing to bifurcation in the majority of cases, and sometimes trifurcation, and we have seen a very nice case during this session. It's more calcified because the patients are older. So the mean age is 3 or 4 years older than other patients when you treat left main. It's the only bifurcation when you have to deal with the ostium. So at the same time, you have to treat both an ostial lesion in at least 70% of cases and a bifurcation lesion. And in the majority of cases, it's a T-shaped angulation, which can be a problem in terms of selecting the optimal two-stent technique when we have to use two stents. So let's start with this case and look at the tips and tricks one. So I think the most important is to have a strategy. And starting with a good support is very important. To have an optimal working view, but not only for the bifurcation, which can be in this case the spider view or areocaudal, but also to see the ostium of the left main, which is diseased in this case. So you have to treat up to the ostium of the left main. Should we use the hemodynamic support? You think this patient is 85 years old. There is a chronic occlusion of the right coronary artery. Should we use debugging devices? And maybe, so now we'll start with DCB in this case, but it's not available in France. Start with 2 wires or even sometimes 3 wires when you have a trifurcation lesion. Select the optimal diameter and think provisional. Because as you said, Sunao, if we can end the procedure with 1 stent, we know that the outcome would be very good. Of course, if we need 2 stents, we have to use 2 stents. So this is data from Excel, and you know that when you can use 1 stent, you have really a better outcome as compared to 2 stents. So in this case, what I do first is to reconstruct the vessel and try to imagine what will be the best approach in this case. And you can see that, in fact, this lesion is really a 1-0-1 lesion that maybe can be treated with only 1 stent. So because the lesion is toward the circ, we decide to go with a non-compliant balloon, high pressure, with 2 wires, and pre-dilate the circ and the left main. And then we put a stent, and in a good optimal view, you will be able to select the optimal positioning up to the ostium. And of course, we select the stent according to the characteristics of the stent. So in this case, despite the fact that the LED is close to 3.0, we use a 3.5 because we know that the expansion capacity of the stent 3.5 will be up to 5 or 5.5, not 3.0. Then we have done the pot, and now after exchanging wires, we have do kissing bell inflation, and we do pot up to the ostium of the lesion. And this is the final result, which I think is very acceptable with 1 stent. Of course, we have still some disease at the level of the proximal LED, but not significant. And the procedure is finished. So now let's look at the more complex case with tips and tricks number 2. Of course, you can see the patient is an old woman, 88, with a very unstable angina. Surgery is not possible in this patient. And of course, we have to think about the optimal strategy in order not to have a complication in this case. So the first thing is to look at the difficulty. Where are the difficulties? Should we stand first toward the LED or the circ? And of course, depending on the strategy that you will use, it could be different. Should we use debulking? But I think in this case, it could be challenging in terms of risk of slow flow or no reflow. And look at the right. So you can see that there is also a lot of disease in the right. And the first thing that maybe you could think that we should treat the right first before treating the left main. But you can see also that there is good connection from the right to the left system. You see here. So I decide not to treat the right first because in case of complication in the right, the patient will die on the table. And the right will be treated later. So I will skip this because you already know the different techniques that we can use. And so now let's reconstruct the vessel. And you can see that the difficulty in this case is, of course, calcification, but also access toward the LED, which can be very challenging in this case. And we use, in this case, we try with a conventional wire, Workhorse wire, we failed. And we use this here, a feeder FC wire with a lot of angulation. You can see that we are able to access at the ostium of the LED. But if we push, the wire will prolapse in the circ. So the technique is turning wheel. So you engage the ostium and then turn the wire a little bit, and then it will advance in the LED. So very, very important technique. Then we wire both branches, and it was easy to wire the circ, pre-dilate the LED, non-compliant balloon, and stand the LED up to the ostium. We have done the proximal optimization technique, as you can see. We start with intra-aortic balloon pump because we saw that the patient, we need time to do a good job. And with the intra-aortic balloon pump, we have a little bit more time in terms of ischemia during balloon dilatation. After POT, we deploy a stent in a T-shaped configuration. So this is a tap technique. And then we have done kissing balloon inflation on final POT. And this is the final result, which I think is very acceptable. And the right coronary artery was treated 1 month later. Let's look at another case, a younger patient coming for unstable angina. You can see that the patient, so we have done acutely the coronary angiogram, and you can see this very tight lesion of the left main up to the ostium, which is a 100 lesion. And in this case, one of the questions is, what is the size? What is the reference of this left main? Of course, you can use IVUS or OCT, but in this case, I think it will be very, the patient was unstable, so very difficult to use intracoronary imaging. So we just use first a good stability and safety. So wire immediately any branch without doing injection. And of course, we have to do a good ostial scaffolding. And should we stand toward the LED or the circ? I think we have both are okay in this case. They are quite the same size. Now, in terms of reference, we know that by QCA, the LED is 3.7, the circ is 3.9. So we know the reference, which is 5.1. So very important to select a stent according to the distal reference of the LED, so 3.7. So we use a 3.5, high pressure, and go to a cranial view to, again, have optimal positioning of the stent at the ostium of the left main. Then we deploy the stent, we do a POT, we exchange wire going through a distal thread. And of course, you know that by doing a POT, you pose a stent proximally, and you also make some projection of metal in the side branch, which make easier access toward the distal thread. But of course, if you go through distal thread, you have this kind of appearance of the stent which treat both LAD, left main, and the ostium of the circ. And of course, you may say, we don't know if you are in the distal thread, but if you use a wire proximally, you can check that you are really close to the carina, like in this case. So you know that you are in the distal thread. So you can do a kissing bone inflation, a final pot, and then you may have this kind of result, which I think, again, very acceptable. Now let's go to difficult side branch access. Of course, there is many techniques to solve this issue, and you can understand that in this case, we have a 100 or 101 lesion of the left main, and access toward the circ can be very difficult. So we try with the conventional wire and we failed. So it's very important to look carefully at the lesion. And the pullback technique, of course, should be used. But sometimes you have to modify the wire. Sometimes you have to use rotemlator, but that's not the case in this case. And the long U-shaped reverse wire technique in this particular case can be a very useful technique. Of course, angulated microcatheter can be also useful, and double lumen. And the angulated microcatheter could be very useful in your case, Dr. Park, when you fail to recross toward the diagonal. So in this case, you just make a long U-shaped reverse wire technique. You pull back the wire, and you can see that just by pulling back, you engage the circ, and then you can wire the circ easily. So then we have two wires. We pre-dilate with non-compliant balloon the circ, then we stent from the ostium of the left main up to the lesion, do proximal optimization technique, kissing bone inflation, and this is the final result with only one stent. Another problem is in this particular case, you have a calcification, diffuse disease. The patient is a woman, 82, contraindicated for surgery. And so we decide to treat this left main. And you can see that it's very difficult because the size is very small because of diffuse disease. So selection of the stent that you may use is very important in this particular case, because if the stent is too large, you push the carina and you close the side branch. So my colleagues use a 2.5 stent, which looks very small as compared to what should be the reference of this case. But after that, the side branch was closed with, of course, acute chest pain, etc. So it's just because we push the carina. Of course, we could have used a different technique, DCB, DK crush, etc. But even when you have two wires, of course, the first step is to repot, because by doing pot, you may restore the flow. And it's very frequent. In about 50% of cases, you may restore the flow. And if you are not able to restore the flow, so this is what we have done. We have pushed the carina, closed the vessel. You can use a wire which is outside of the stent, just to restore the flow. A 1.5 or 1.0 balloon can be very useful to restore the flow. And then when you have, again, a flow in the circ, it will be easy to wire from the main branch stents and do kissing bone inflation. So this is what we have done. We have restored the flow with a small balloon, 1.5. You can see now we have a good flow, and we're able to rewire through the main branch stents, and then do a kissing bone inflation and stent the marginal with a good result. Of course, there is disease more distally, but we saw that it would be enough. Left hand control is also a very important point when you do left main. So this left main case is relatively a simple case. It's a 1-0-0 lesion. It's a quadrifurcation. And the operator starts with 2 wires. So this is a cranial view, the spider view. start with 2 wires, stent the main branch, exchange wires, do kissing by inflation. And this is the result after kissing by inflation. And maybe you can see that there is something which is not very clear. We should not have this kind of result. And if you do stent boost, and I think it's very important to do this technique, so we do it always, you can see that there is something which was done not correctly. So we have a longitudinal deformation of the stent. And there is many mechanisms, but in this case, the main mechanism was that they pull back the gel wire without controlling the guiding catheter with the left hand. So if you do that, the guiding catheter is engaging the left main and then push the stent and make a huge deformation of the stent. You can have also this complication when you pull back too early the balloon, which is not fully deflated, and then you have attraction of the stent, of the guiding catheter toward the stent. We learned from Excel that this longitudinal compression of the stent is associated with very poor outcome. So the MACE rate is doubled at 3 years follow-up in Excel. So very important to avoid this kind of complication, which is not visible in all cases, except if you do IVUS or OCT. So this is my conclusion. So of course, I have not time to develop a lot of tips and tricks, but I think this one are the most important. So start by building a strategy, discuss with experienced colleagues. I strongly believe in the compagnonnage approach for younger people who can learn with more experienced people. Think provisional, because we know that if you can end the procedure with one stent, we have better outcome. Know the stent that you are using. So a very important point, because if you use a 3.0 stent, in the majority of cases, it will not scaffold correctly the left main. Know the solution in case of difficult access. So there is a lot of papers about that, and you should know that, of course. Proximal optimization is crucial, even more when you are treating left main, because there is a big difference between the size of the LAD and the left main, or circ on the left main. Very important to restore the functional anatomy with the 3 diameters and the carina in the middle of the bifurcation. And of course, use 2 stents when needed. I think there is a big misunderstanding about recent studies showing that one stent is less good than 2. But of course, when you need to use 2, you should use 2. So, and it was not the case in these last studies. And of course, use intracorneal imaging, at least where in doubt, but also when you are in the learning phase. Thank you very much for your attention.
Thanks, Thierry, for sharing the great tips and tricks from the experts. So I think we have around 10 minutes for discussion for the cases and also the important lecture from Thierry.
But Thierry, congratulations. It's one of the best lectures I heard about bifurcations. Very practical, and I agree with everything you said. So it's especially, you know how much I push for 2 stents, but your last statement, use 2 stents when needed, only when needed. You don't make a scene if you use 2 stents, but you don't make a scene if you use 1 stent. One point I like to make, we are now try to avoid double stenting, especially in diagonal, in OM, in non very large branches. And we work with 2 wires, 1 pressure wire and 1 regular wire. We do optimal pre-dilatation, and we measure the distal gradient in the side branch, because we have the pressure wire. We don't disconnect, because every time we disconnect, we lose calibration. We keep 2 wires. And then even if we have a small dissection, if we have a pressure gradient less than 10, we just do drug-coated balloon. and we don't stent. And we have been doing these silently for more than 1 year. And so far, I tell you, we did not have occlusions. If the pressure gradient is high or bad result, we do T-stenting. Otherwise, but I tell you, many side branches, even with a mediocre result, have a very low gradient, like 2, 3, 5, and we do drug-coated balloon, and as a follow-up, they don't look great, but they look okay. So sometimes why losing so much time, so much efforts when you can get a good result?
I fully agree with you, Antonio, and this is something that we learned from Dr. Koo. So side branch relevance is also something very important to discuss before doing the strategy, because there is many side branches which are not relevant. So we just want to keep it open, but they will induce ischemia less than 2 territories, and also FFR, which in many cases is normal, even when the vessel is pinched. So maybe Dr. Koo, you can comment about that.
So I think that Antonio's suggestion is, I think it really makes sense in terms of fluid dynamics, because that there are many suggestions, even for the main branch, there are doctors who are now performing FFR guided DCB after balloon angioplasty. Because that when there's a dissection, we simply worried about the possibility of disease progression and acute abruption. But if there's a good flow, as Antonio suggested, if there's no significant resting gradient and hyperemic gradient, I think the chance of progression and abrupt closure can be very, very low. So in that perspective, I think that the physiology-guided DCB can be really an option for the bifurcation lesion, generally for relatively short osteal lesions, so that the side branch. And another important point Antonio pointed out was that the main branch, if there is a 50%, 60% stenosis, there should be a significant gradient. But for side branch, relatively small territory, there's generally more discordance between pressure gradient or flow decrease and anatomical stenosis severity. So that if someone really want to do something and guided by the hemodynamics, I think it doesn't make a big matter whether using resting or hyperemic, but the Antonio's suggestion may really makes a big sense to me.
Yeah, I like to use resting because it goes back to the history. Grunzig liked the resting gradient.
Yeah,
in the history.
Right, so.
Dr. Koo, actually, there were 2 recent Korean studies that actually, merit some kind of discussions, particularly for non-left main bifurcations lesions. We have Dr. Young studies who suggest to us that, most of the diagonal branches actually subtends very limited myocardium. Myocardial ischemia was on nuclear scan was like less than 10% for almost all the cases. And even from fractional myocardial mass, it's also 50% actually have more than 10% of myocardial mass. And the second study also is that most of the closure of the side branch actually caused no symptom, no arrhythmia, no myocardial infarction. So sometimes when we go too far, we go to a great extent in trying to preserve a diagonal. Besides just keeping open, we put in stents and so forth. I think maybe we have to have certain perspective with regard to those territories which are less than the big bifurcation, unlike the left main bifurcation.
Right. So I think that that's a good point. So that in this kind of a expert session, we are showing lots of stenting with the problem solving, but it does not. We don't want to say that this can be applied for all bifurcation lesions. As you just point out, when we recently analyzed our data, that the 1 out of 10 diagonal branches applies around 10%, so that the most diagonal branches may not deserve or additional stenting, but also that in a recent definition 2 trial, we have to remind that the mean main branch lesion length was 14 millimeter and side branch lesion length was 20 millimeter. So which is kind of not a usual bifurcation lesion, so that for big branches. But another viewpoint is that we can do two stenting when needed, because it's not, as Antonio mentioned, it's not sin. It's not making a sin, because at the second generation drug stenting era, one stent, two stent may not be a big difference. So that I think those are the important point we should make. We just don't want to show that we can fix this lesion with this way and that way, but we have to be logical and scientific and be smart before selecting the right strategy.
Yeah, just to go back to the definition 2 study, as you mentioned, I think we cannot treat with one stent a side branch lesion, bifurcation with side branch lesion, which in mean is 20 millimeter in length. So that's why, of course, two stent technique win. But in these studies, they showed also that when the side branch lesion length is less than 10%, then provisional is as good as two stent technique. So, and of course, now in the game, there is also the regulating balloon, as it was mentioned by Antonio, and also side branch relevance. I think it's something which should look carefully before deciding which technique we should use. But of course, in the left main, it's a little bit different, because the side branch usually is very important.
I have a question to Dr. Koo. In intermediate left main stenosis, if we use FFR and or IFR, sometimes the result is not the same. So there is, in case we have discordance between IFR and FFR, what is your view how to solve it? Usually we use IFOS, of course, but what is your personal opinion? And the second question is, what is the role of QFR in left main situation?
Okay, so that the QFR, we still don't have a solid data for the ostial lesion and the true bifurcation lesion. So we definitely need more data on QFR. And for the resting hyperemia discordance, I think we can choose both. If both are bad, they are really bad. But if there's a discordance, it's worse than both negative. So that I think you can use your flexibility and using imaging information to decide your treatment strategy. Because when you do a 5-year follow-up, actually during 2-year follow-up, the discordant case has a similar outcome than both negative. But at 5-year follow-up, the discordant case has a similar outcome than both positive. So that if you just look for 2 years, just do a medical treatment, but 5 years, you may do a PCI if one is low. So that's my suggestion from my data. Okay, so I think we are almost at the end. So Dr. Colombo, can you summarize and close the session for us, please?
So I think we reviewed what I call modern approach to bifurcation located in the left main and in the other vessels. I think the most important point to me is that you should use the two-stent technique only when needed. And if you use the two-stent technique, you have to be very meticulous, because every time you place an additional stent, you expose yourself to higher risk of thrombosis. So you must dilate the vessel very well, and you should have a low threshold to use IVUS. Especially, I may add, if you use the two-stent technique. If you have done one stent and if you plan to go to two stent and you go to the crush, always consider pot, especially when you place the first stent in the side branch, because that will facilitate crossing into the side branch. I believe these are the most important points, and that's it. Thank you for your possibility to be part of this nice group. And every time I think I learn something. Thank you.
Thank you, and bye-bye.
Thank you. Great. Wonderful. Thank you.